Subepithelial connective tissue graft. According to Low H in 1992, gingival recession is defined as the apical shift of marginal gingiva from its normal position on the crown of the tooth to levels on the root surface beyond the cemento-enamel junction. There are various techniques to manage the gingival recession, including the pedicle soft tissue graft, free soft tissue graft, and additive treatments. And out of all these procedures, the gold standard of gingival recession treatment is surgery with an autogenous subepithelial connective tissue graft. The technique was introduced by Langer and Langer in 1985. The predictability and superior aesthetics provided by this technique makes it the gold standard. Subepithelial connective tissue graft is indicated where the aesthetics is of prime concern, covering multiple denuded roots, and in the areas where there is insufficient width of attached gingiva in the adjacent teeth. The advantages of the technique include the double blood supply at the recipient site from the underlying periosteum and the overlying recipient flap. The donor site is a closed wound, so there is only less post-operative discomfort. The connective tissue carries the genetic message for the overlying epithelium to be keratinized. The technique is aesthetically pleasing, and this is applicable for gingival recession on multiple teeth. The disadvantages include technically demanding. Because a thick graft is used, the grafted tissue is also thick. Gingivoplasty may be necessary post-operatively to obtain a better morphology. So, subepithelial connective tissue graft is a detached connective tissue graft that is placed beneath a partial thickness flap. The variation of the free gingival graft provides a tissue graft with a nutrient supply on two surfaces. The technique includes preparing the recipient site. A partial thickness flap is reflected with a horizontal incision 2 mm from the tip of the papilla, and two vertical incisions of 1 to 2 mm are made from the gingival margin of the adjoining teeth. These incisions should extend at least 1 tooth wider mesiodistally than the area of gingival recession. Now extend the flap to the mucobuccal fold. Step 2 involves the root planing and scaling on the exposed root surfaces, which cleans the root surface and reduces the facial convexity. Step 3 is to prepare the donor site to harvest the graft. The common donor area is a palate between the canine and first molars, 2 to 3 mm apical to the gingival margin. The technique is the trapdoor technique or a single incision technique. The trapdoor technique includes giving a horizontal incision along the palate at 5 to 6 mm from the gingival margin of molars and premolars. And two vertical incisions are given perpendicularly from the ends of the horizontal incisions. The flap is reflected as a partial thickness flap, and this technique of reflecting the flap by giving one horizontal incisions and two vertical incisions on either side is the trapdoor technique. Once the partial thickness flap is reflected, you can see the connective tissue bed. So now by giving 4 incisions, excise the underlying connective tissue carefully using a sharp blade. Reposition the epithelial flap and suture it with a resorbable or a non-resorbable suture. So this is the connective tissue harvesting technique by using a trapdoor technique. By giving a horizontal incisions 2 to 3 mm from the gingival margins of the molars and premolars, and connecting these horizontal incisions, 2 perpendicular incisions are given. A partial thickness flap is reflected, and the connective tissue bed is harvested. Once it is harvested, reposition the flap and suture it. The step 4 is to insert the excised graft tissue into the space between the root and the previously prepared flap. So it's placed so that it covers the denuded root surface up to the cemento-enamel junction or the crest of the bone. The graft is sutured into place with a 5-0 sling suture through the graft and the interdental papilla. The flap is then sutured into the place with a similar 5-0 sling suture. Now cover the wound with a sterile foil and a surgical dressing or the perio pack is given. And after 7 days, the pack and the sutures are removed. So once again, the steps include, first is the preparing the recipient site by giving a horizontal incision 2 millimeter from the tip of the papilla and 2 vertical incisions 1 to 2 millimeter away from the gingival margins of the adjoining teeth, and make sure these incisions should extend at least 1 tooth mesiodistally wider than the actual gingival recession. Now extend the flap to the mucobuccal fold and thoroughly scale and root plane the teeth. Once this is done, cover it with a moist gauze and harvest the connective tissue from the palate. The area is between the canine and the first molars, 2 to 3 millimeters apical to the gingival margin. To make sure the incision should not cross the mid-palatine rapid. And the technique is by giving the horizontal incision 5 to 6 millimeter from the gingival margins of the molars and premolars, and 2 vertical incisions which connects the horizontal incisions, giving perpendicularly. Partial thickness flap is reflected and the connective tissue bed is harvested, and the flap is repositioned and sutured. Now the excise graft is inserted into the space between the root and the previously prepared flap, and it is placed in such a way that it covers up to the cemento-enamel junction of the receded or the denuded root surface. The graft is positioned with the 5-0 sling suture, and the flap is sutured in the place with a similar 5-0 sling suture. A perio pack is given, and the dressings can be removed and the sutures can be removed after 7 to 10 days. So the aesthetic results are favorable with this technique because the donor tissue is a connective tissue and the donor site heals by the primary injection. But still, the causes for the failure of the connective tissue graft techniques include the recipient bed may be too small to supply. Sometimes when you reflect the flap penetrations occurs. There can be inadequate root planing or insufficient blood supply, or maybe the graft you harvested may be too small or too thick. So these are the reasons why the connective tissue graft fails. Coming to the healing of the subepithelial connective tissue graft. So as soon as we suture the flap into position, there will be a fibrous organization of the interface between the graft and the recipient bed, which occurs within 2 to several days. So during the first day, the connective tissue, it becomes edematous and it disorganized, and it undergoes degeneration and lysis of some of its elements. So as the healing progresses, the edema is resolved and degenerated connective tissue will be replaced by a new granulation tissue. The revascularization of the graft, it starts by a second or a third day. The healing of the graft of an intermediate thickness, that is about 0.75 millimeter, will be completed by 10.5 weeks. And for those with thick graft, that is 1.75 millimeters, will require 16 weeks or longer. So many of the graft vessels degenerate and are replaced by the new ones. and some of these participate in the new circulation. The central section of the surface is the last to vascularize, but this will be completed by 10th day. So the main events are the fibrous organization between the graft and the recipient bed. The connective tissue becomes edematous and disorganized and undergoes lysis. And as the healing progresses, the edema will be resolved and the degenerated connective tissue will be replaced by the granulation tissue. And next stage is the revascularization, which starts by the second or the third day. And the healing of the intermediate thickness is which will take about 10.5 weeks. And for those thick grafts require 16 weeks or longer. So this is the healing of the subepithelial connective tissue graft. Now coming to the difference between the gingival graft and the connective tissue graft. So gingival graft, it cannot be done in areas where aesthetics is of prime concern, while connective tissue graft can be done in areas where aesthetics is of prime concern. In gingival graft, the palatal wound is more invasive and it's slower to heal and it's more prone to hemorrhage, because the healing is by secondary intention. The wound will be open and the healing is by secondary intention. While the connective tissue graft technique, since we are reflecting a partial thickness flap, and after that we are harvesting the connective tissue and we replace the flap back to the position and suture it. So there is only minimal palatal trauma and healing is by primary intention. So there will be more discomfort with the gingival graft for the patient compared to the connective tissue graft. And for gingival graft, the blood supply is available only from one surface, while for connective tissue graft, there will be a dual blood supply. So more fast healing can be there. The gingival graft is indicated where there is a need to increase the keratinized tissue in an area with minimal attached gingiva. That is the most common indication for the gingival graft, to increase the attached gingiva. While connective tissue graft is indicated for aesthetic root coverage, especially in the anterior teeth. So these are the differences from the between the gingival graft and the connective tissue graft. Thank you.